Good day. Thank you for joining our demonstration, Mitigating Audit Risk and Ensuring Profitability. Today, Brenda Turner, Product Consultant, will focus on ways you can proactively manage compliance, reduce your risk for takebacks, and improve audit appeal success. Before we get started, I wanted to mention that your lines are muted, and if you'd like to ask a question during the session, please type it in the Q&A panel, and our presenter will address it at the end. Be sure to select all panelists in the drop-down. The session is being recorded, and we'll send out a playback and slides in the coming days. Now I'd like to turn it over to Brenda, who will start us off. Brenda?
Thanks, Elisa. Thank you, everyone, for joining today. As Elisa mentioned, we're going to be talking about mitigating risk within the healthcare environment. But before we get started, I am going to actually be in a live demo environment. There's a few slides I'm going to cover just to talk about kind of what's happening currently, what we're seeing in our healthcare market trends, and just analytics and technology as a whole. So when we're looking at current market trends in healthcare, we can see that since the passage of the Affordable Care Act in 2010, there has been a shift in care moving away from inpatient and moving in favor towards outpatient and ambulatory care settings. Increasingly, organizations have begun investing in computer-assisted coding and natural language processing. And over the last few years, payers have begun reimbursing providers based on a fee for value as opposed to a fee for service. And as a result, providers have been challenged with analyzing their data to achieve better outcomes. Do you have access to your own data? Have you begun using advanced technology such as machine learning or predictive analytics? And you may be wondering, what does all this mean? And how does all of this technology assist me with decision support? And ultimately, does more data and more analysis actually equal better outcomes? So according to a recent Gartner survey, there has been a significant increase in investment in the areas of business intelligence, data analytics, cybersecurity, and integration. We can also see upward trends in mobile apps and cloud-based services, which allow flexibility in the workplace. Work from home and/or remote locations is becoming more common, especially today, given everything that we're dealing with the COVID-19 virus. And this trend points to a decrease in investment in infrastructure and data centers because providers are moving towards cloud-based or hosted data warehouses instead of building their own internally. Let's not ignore the barriers to analytic success. Providers are struggling with managing multiple sources of data in different formats. And the first key to success in data analytics is data orchestration, integrating your data and using a single source of truth across your organization. Bringing in multiple disparate data sets into one centralized location allows providers to analyze large volumes of complex data. It allows you to create increased visualization and insight into key metrics, and eventually can lead you down the road to advanced analytics, the new world of machine learning and predictive analytics, which will help providers streamline and automate their processes, ultimately leading to improved efficiency and a reduction in cost. You may be wondering, how can analytics help me? I've barely got any time to complete my day-to-day responsibilities. But one thing that analytics can do for you today is allow you to become more self-service. Accessing your own data provides adaptability and flexibility. You'll be able to identify areas of opportunity for improvement and do root cause analysis. You'll be able to see trends in your data and determine what the areas of focus should be. You'll be able to start proactively addressing your problems within your organization and even pinpoint which service areas or departments have the most opportunity. Analytics creates efficiencies in your workflow and provides you with the ability to automate. And lastly, and perhaps most importantly, analytics helps manage and control information by supporting your organization's activities and ensuring compliance with its duties. So that's kind of it for the slide. I'm going to switch over now into a live demo environment, and just give me a second, and I will share my screen. All right. So for today, as we mentioned, we're going to be talking about how we mitigate risk within a provider space. And so one of the best things that we can do from a healthcare perspective, from a compliance angle, is always trying to keep an eye on what our current risks are. And so how do we do that? We do risk assessments. And so basically looking across your organization and identifying outliers or low-hanging fruits, things that you can see. And so the power of analytics is that you can quickly see and identify if you have specific risks, whether it's from a payer perspective. So if we're looking at this first chart, we can actually see, based off of, these three facilities, we can see the risk by the payer. So as we hover over, we can see, we've got a significant amount of risk based in our Medicare and our Medicare Advantage population in the Crawford facility. So right then and there, I already can see just visually that Crawford presents the most amount of risk across my organization. So if I have limited resources, I'm probably going to spend the most amount of time there. And then even further, I'm going to spend the most amount of time in those particular payers where I'm seeing that those large volumes of risk. As you scroll down, you can trend it over a period of time and look at, am I seeing an uptick? Am I largely flat? Where am I seeing the most amount of risk from? Is there a particular month? Can you attribute that to something? Did you see a high spike in your audit ADR requests? Was there a holiday season and perhaps you had fewer claims volume? Those are the kinds of questions you can actually answer by analyzing the data. When we're looking at risks, we can also categorize them. So we know that the auditors are looking at multiple different things, short stays and DRG denials and bundled payments and unit count violations and hacks and all of those different things. So when we categorize our risks, we can actually then see, where do we have the most amount of risk within our organization based from a categorical perspective. Easily hovering over, you can see the values, which is, the volume of claims that have flagged during this time frame for each of the different categories. Within those categories, we have designated specific risk rules. And so you'll notice up here, we've got our medically unlikely edits, we've got billing for radiology services in the ED, review DRG for missing CCs and MCCs, review another MUE chart for based off of specifically for a specific payer, and then add-on codes without primary code. And we'll get a little bit more into that in the next slide, in the next chart that I show you. But essentially what this allows you to do is determine from your organization, not only from a particular payer and then within a risk category, what's the specific risk to my organization? What are those things that we're seeing? And so by developing a series of algorithms, we're able to flag claims that come through that have potential risks based off of the billing and coding that we're able to get from a claims perspective. On the inpatient side, we can see where our highest level of volume of claims is by MSDRG. And no surprise here that you can see simple pneumonia and pleurisy showing it's at the highest based off of the respiratory ailments that we're seeing within the COVID virus. We can see that there's a significant volume here. Further breaking it down, we can actually analyze where we're seeing risk in particular physician populations. So not only can we see from a very high level, we can get all the way down to who are the physicians that have the most amount of claims during this time frame that have claims that have flagged for risk. Conversely, we know that it's not always the physicians who are poorly documenting. It could also be that we're having a coder who's not capturing the appropriate specificity within their coding. And so when we do a root cause analysis, when we gather those claims, we drill down into those claims, which you can easily do from here is just drill down directly into those claims and see the claim details. What it allows you to do is when you pull those medical records and you review the documentation, you can check it for its accuracy and completeness. And then you can also compare it then to the claim to see whether or not it was coded appropriately. And then go back and either have a training and education with either the physician or the coder. But you have this ability to do a root cause analysis within your data to determine where those risks are occurring. When I switch over to the next tab over, as I mentioned, we also, within these categories, we have the specific risk rules. So just over here to the side, we'll see we've got rules from procedure related. As I mentioned before, unit count, we've got diagnosis-related short stay, which is another big one for the RACs, as well as for some of commercial payers when you're thinking about things like medical necessity and appropriate sense of service of care. That's kind of where we would think about that. We've got our hospital-acquired conditions. We obviously know that, CMS is very interested in hospital-acquired conditions and ensuring that they're being appropriately built out, that the POA is appropriately coded on the claim. And then also things like non-covered service. So as I expand some of these, you'll get an idea for how you can actually, mine your claims to identify specific claims for specific reasons. And then you have an idea of if you're going to do a risk assessment, for example, we know compliance departments are supposed to have an annual work compliance plan. And one of the things that our clients will actually utilize this tool for is to conduct their annual risk assessment to determine what items will be on their compliance plan for the following year. What are those internal audits that they're actually going to conduct? The other thing that happens as well is as you're getting external audit requests, you can actually proactively go in. And so if you know, for example, there's a specific DRG that you've been having trouble with, you can kind of go in and do your own, sorry, there was a question came through. You can actually go in and do your own proactive analysis around specific, DRGs, drill down into those claims, do I am hearing a lot of feedback. If everyone could just mute their line. Thank you. That's much better. When you have the ability to kind of analyze your own claims, you can go in, you can drill down and get to the specific claims that you'd like to do, conduct a random sample audit, and select just those particular claims that you're going to pull into your annual work list. So as I mentioned over here, we can see things like short stay for septicemia, for same-day readmissions. We've got things for short stay cardiac arrhythmia, renal failure, and so on and so forth. And as we expand each of these categories, we can see that there's quite a bit that we're able to do just from a claims perspective. And I should mention that. So this is actually a retrospective review. So essentially what it allows you to do is do a short look back. Once the claims have been built out, you can actually then start mining your claims to identify these areas of risk. But again, as long as there is data going out, there's really no limit to how you're able to analyze it. So as I mentioned, if you wanted to look at it from a particular code, as I mentioned before, it's a DRG perspective, but you could also look at things like CPTs or modifiers. And if you have been either targeted for particular audits or you're seeing a high spike into your denials, you can proactively look at those things and see, if there's a preventive way, if there's training and education, if there's something that's being done incorrectly. We've also even been able to identify sometimes that there may be something wrong with the scrubber. Perhaps, the NCCI edits are supposed to be included in the scrubber, and maybe some of those things are being missed. Again, it's all done with root cause analysis. So, for example, like some of your MUEs, maybe they're just being billed out incorrectly, or we need to apply an appropriate modifier because those services really are required and recommended by the physician. So having those conversations and starting that dialogue allows you to learn more about what's going on within your organization. So over here, as I mentioned, you can see things from a diagnosis-related perspective. So looking for things like billing for polysomnography and sleep studies. We know that that was a big target of the OIG for the last few years. Billing for unacceptable principal diagnosis code. So again, another NCCI edit there. TAVR is another one that's been highly regulated over the last few years. And we also know that all of the major joints have been scrutinized for medical necessity, hip replacements and things like that. So we have the ability to kind of allow our clients to proactively identify those areas where they may be seeing high volume. If you notice over here, the metrics that we have available, we can see the volume of claims, the percentage of total, the average charges, and then payment information as well. And I can kind of scroll down. You can see this a little bit better when I collapse that. So you can see all of the different metrics that you have available to you. total payments, and then the total amount at risk. So what it allows you to do is determine, okay, so if I have limited resources and I need to start somewhere and I'm not sure where to go, I can see what are the particular facilities. Are there particular payers? Is it a particular doctor? Is there a certain category? So within each of these different risk areas, we're able to kind of review all of that data and then analyze it and figure out where it is that we're seeing the most amount of risk, and then determine where we're going to place our resources. When we look at it from the alternative side, the opposite side of things, right? So let's just say we've done training and education of our physicians and our coders, and we've ensured that all of our systems are up to date and they're current and they're accurate. And we've proactively started analyzing our risk, and we've started doing risk assessments, and we've started doing audits, and we're doing our best to train and educate our staff. With all of that said and done, we're still never going to be able to prevent, number one, audits, and number two, denials. The idea behind this is that we actually just want to try to reduce that. We know that in this environment, payers are always going to continue to audit us and continue to deny our claims based off of, whether or not it's a perfectly rational reason, or if you can find something that is being done inappropriately. So what this solution also allows you to do is look at it from a denials perspective. So once we know that we've identified certain risks, the other way of looking at this is saying, okay, well, let's see where we have high denial counts. So, and we can do the same kind of root cause analysis with that as well. So is it by a particular payer? And you'll notice up here, you have the ability to filter by that. So if you know, for example, if you've done your risk assessment and you've identified that there's a particular facility where you're seeing a large amount of risk, you can then go to a denials report and look to see if you're seeing that same trend within your denials. So we knew before that the Crawford facility was the one that had the most amount of risk. We can now look at it from a denials perspective and see, are we seeing it on the opposite side? Are we also seeing a high volume of denials within that same facility or within that same payer? So here we can kind of look at it from a trended over a period of time. And as I hover over my mouse, you can see from each of the different values, not only just the total volume, but then also the dollar amount that represents in denials. And we can kind of see that in each of these different areas. So for coding, we can see for coverage, and we can see for documentation each of the different months. And we can see very easily from a graph view where we have the most amount. And so we can see January and August were our top trending months in terms of denials. When we talk about denials, we need to look at it from the denial reason code or the claim adjustment reason code. And so by analyzing your remits, you can actually take that information and see from a denials perspective, what are the reason codes that have triggered the most amount of denials for your organization. So we can very easily see over here, non-covered charges is the top trending one, followed closely, not so closely, by payer deems the information submitted does not support this level of service. So that's going to be one of your kind of medical necessity or missing documentation. So these were ones where you're going to need to have a chart auditor, so whoever that is within your organization, it could be a case manager. You may have a particular audit team. Obviously, it's going to be someone with some clinical expertise because they're going to be doing medical necessity review of that claim. And then followed again by additional reason code 50. These are also non-covered services based on medical necessity. So we usually see within most of our organizations the 150 and the 50 being usually kind of towards the upper end of the spectrum on these particular charts. That's just kind of a trend that I've noticed in some of our clients' data. And those, again, lead to your medical necessity, your ADRs. And that's, again, something that's going to trigger audit activity. So if you can proactively look at these and see and identify if there's any trends behind that. Is it, is it a particular physician? Is it a certain DRG that we're having issues with? That'll allow you to kind of have a way forward to know how to fix that error. Maybe we need to beef up our documentation because we keep getting denied for this one particular DRG, either group or that particular DRG itself. I've spoken about this already, but we can also see it by the physician, but as well, you can look at it by the physician specialty. So not only is it just the particular physician, we can see whether or not, we have a high risk based off of a group of physicians. So we can see over here that internal medicine, we've had the largest amount of denials. So those are the physicians, that group of physicians. If we're going to have a training session, we can do it during grand rounds or, set up some training time. We know where we need to limit our training resources. Who are the outliers? Where are we seeing all of this risk? Where are we seeing all of these denials? And so very easily from a data perspective, you can make those key decisions. And then further drilling down, you can see it specifically by the physicians themselves. So again, the metrics that we're able to look at based off of just claims and remit information is extremely powerful to your organization. You can look at it by, the total number of claims that have been denied based off of, how many were adjudicated, how many were fully denied, what was the adjustment rate. You can see the denial amount. How much is this costing your organization? How much, are we really looking at in terms of denials each year? I mean, it's very challenging, especially, during this pandemic, looking at how many, canceled surgeries. We're seeing, not as many elective surgeries. We're seeing, patients kind of switching more towards telemedicine because they're afraid to come into the organization. So having an idea of what that financial impact is always important, but I think so even more critically today. And then seeing the denial rates as well. When we look at it from physician perspective and, when we want to see what's our performance, so how are our physicians performing compared to each other? And so, not only are you seeing it from a risk perspective and a denials perspective, but then let's also look at our physicians' metrics, right? So we know that increased CMI, increased CCMC capture rate, and reduction in unspecified codes actually lead to increase in reimbursement. So all of these things kind of wrap around each other if you look at it from a mid-cycle perspective. So keeping a track on, the overall metrics of your physician group will help you. So you can trend this over a period of time. Are you seeing a dip in your CMI? Is it largely flat? How is your CCMC capture rate, your unspecified code usage? What's your average SLI and ROM? What's your average length of stay? So we know, that leads to resources. How long are patients staying in the hospital? What's your mortality index? That goes to quality of care. And what's your readmissions and your complications? These are all things that you can look at and review and have an idea of what's the overall financial health of your organization using data analytics. And then one last thing that we can actually do is, because we are bringing in all of this different data, we can collaborate and put it onto one kind of simplistic view. And we have, these dashboard views, which allows you to look at multiple different metrics from all across your organization, all in one view. So if we're looking at things like audit success and our hospital-acquired conditions, we can kind of see that risk that we talked about before. We can see some denials activity. We can see our audit volume, so managing your audit workflows. This all talks about how everything is being managed from an organizational perspective. We can also look at things like your discharge not final billed, your discharge not final coded, to see how quickly we're getting claims coded and billed and out the door, so we know if that's causing a lag and that's leading to a reduction in reimbursement themselves. We can trend things over periods of time. We can look at things like your CMI. We can break it down. We can look at things by a service line or even a particular payer and determine, again, where we're seeing all of this different activity within our organization. So I can't stress enough the power of analytics and being able to analyze your organization, know what's kind of going on from a risk perspective, from a denials perspective, from an opportunity perspective, looking at ways to improve your physician CDI. Can we improve our CMI? Can we improve our CCMC capture rate and therefore lead to higher reimbursement, fewer audit takebacks, fewer audit requests, fewer denials? Ultimately, all of these things reviewed holistically and allows us to empower ourselves to make better informed decisions and know where to put our resources. So with all of that said, I'm going to pause here and see if there's any questions.
We do have one, and this one is, it says, if we have limited resources for conducting risk assessments, where do you suggest we focus our efforts?
That's a great question. The thing is that I think that, each organization is different, and you obviously have items that have been reported to you throughout the year. I would say focus on those. So if you've had things that have been directly reported to you, either externally by a patient or by, specific departments, employees, I would focus my efforts there first, because those are things that we, know that have been identified by someone. And so we want to address that to, do a root cause analysis and see if that actually is really an issue within the organization. Beyond that, I would say the two most transparent agencies right now, or organizations that are auditing, are, CMS, which are, your RAC audits, which obviously are paused right now during COVID, but they do have a list on their website that tells you all of the different RAC-approved issues that they're reviewing. I would say take a few off of there that are relevant to your organization. And then we also know the OIG reports out monthly. And so they continue to be highly aggressive with their auditing. So I would definitely suggest that you go out to the OIG website. They keep a list of their issues reported that they're working on actively on their website as well. And then the other thing that you can do, is if you have the opportunity and have an analytics tool, I would do some of that data mining that I was showing you. Look at where you see risks within your organization, whether it's, as I mentioned, is it a particular payer? Is it a particular hospital? Is there a certain physician or coder? Is there a certain code? Analyze your data, get a hold of your data, ask for some reporting, and, make those determinations based off of, what your ability is, collaborate, with your internal audit team. See if there's ways that you can kind of stretch your resources within your organization.
Great. Thanks, Brenda.
Sure.
There are no other questions at this time, so we will wrap. Thank you, Brenda, for presenting today, and thanks for everyone for joining and taking time out of your busy schedules. If at any point you have further questions or need assistance, be sure to let us know, and have a great rest of your day. Thank you.
Thank you. Thanks for joining.